following podcast is part of a certified educational activity titled Intelligently Achieving the Potential of Adjuvant CDK4/6 Inhibition in Reducing Risk of Recurrence while Maintaining QOL in HR-positive, HER2-negative early breast cancer, an AI-driven educational resource for improving MDT collaboration and patient-clinician communication. Access the entire activity and complete the post-test at peerview.com/DEJ860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Erica Hamilton. I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee. I'm happy to join you today for this entitled Intelligently Achieving the Potential of Adjuvant CDK4/6 Inhibition in Reducing the Risk of Recurrence while Maintaining Quality of Life for Patients with Hormone Receptor Positive, HER2 negative early breast cancer. I'm joined by two fantastic colleagues today. The first is Dr. Heather Moore. Would you like to introduce yourself?
Hi, my name is Heather Moore. I am a clinical oncology pharmacist in the breast clinic in Duke Cancer Institute in Durham, North Carolina.
And Kelsey Martin.
Hi, I'm Kelsey Martin. I am a nurse practitioner with Sarah Cannon Oncology Partners, a CRI here in Nashville, Tennessee, and I work with breast cancer patients.
Thank you so much for joining us. We're really going to be focusing on the multidisciplinary aspect of care of these patients, particularly in the adjuvant setting. So, our goals today are really to equip you with knowledge about risk assessment and efficacy and safety of adjuvant CDK4/6 inhibitors, to enhance your skills in formulating specific treatment plans for your patients based on their relevant factors, and then also to improve your ability to implement team based strategy to anticipate, detect, and manage treatment related adverse events, especially around endocrine therapy and CDK4/6 inhibitors, ultimately with a goal to maximize adherence and persistence. So, something new on this session is PeerView's AI Assistant. This is a feature for engaging and exploring the content of this educational activity. You should be able to tap on AI Assistant icon in the toolbar, and there'll be several prompts you can pick from. And if the AI Assistant can't find the answer to your question, it will suggest other topics. So let's get started. We're going to build upon this case throughout our hour together here today. This is a 69-year-old lady. She underwent a routine mammogram and was found to have a mass in the left breast. Mammogram and ultrasound showed this to be about 3.5 centimeters in dimension, and she also had suspicious axillary nodes. She ultimately had a core biopsy of the breast mass, which showed high grade, grade 3 invasive ductal carcinoma, ERPR strongly positive, and HER2 non amplified. She also had her node biopsied, and this was consistent with breast cancer in the lymph node. She had staging scans, which showed no negative disease, and she also had germline BRCA testing, which was also negative. She went on to have a mastectomy and an axillary lymph node dissection, and she ended up with 2.3 centimeters of tumor in the breast. Grade 3 again, 2 out of 3 involved lymph nodes and did have negative margins. So think about this case as we go through the content. We're going to come back later to discuss it with some updates. So, first, I'm going to turn the slides over to Kelsey Martin to talk about a risk based approach for patients with HR positive early breast cancer.
Okay, thank you. Um, so, really, what we're going to talk about is just looking at individualized risk for all these patients. We know with early stage breast cancer, the risk of recurrence can certainly increase as years go on. These graphics are showing us as 5, 10, 15 years go on, the risk of recurrence can just continue to rise for certain patients. And so, those with hormone positive breast cancer, is, certainly those that get chemotherapy, and then even those that, do not receive chemotherapy. Those, not choosing not to do endocrine therapy, they can have an even higher risk of recurrence, up to above 40% at that 15-year mark. And then mortality also increases as we go. It seems going, each incremental 5 years, that those recurrence risks are rising for some of those patients. And then thinking, here on this left graphic, we know that estrogen negative breast cancers, whether triple negative or HER2 positive patients, may have a higher risk of recurrence early, and then can kind of taper off, and kind of see that on that graphic. But our hormone positive patients can have somewhat steady rate of recurrence, and so those patients may not see that same drop off as years go on. And so certainly need to think about patients that would be that would really benefit from some extra adjuvant therapy for their disease. And then looking to on the right, we see that even with endocrine therapy, we can see that risk of recurrence go up as years pass. And so just thinking about what kind of benefit can we give patients, what things can we add to their therapy and to their surveillance to just prevent this cancer from returning. And then thinking about our recurrence risk, certainly some patients will need that chemotherapy and endocrine approach. And so, those that have a higher risk on such as an oncotype assay or some sorts of test like that, those who we think would benefit from chemotherapy, they could still get an equitable response as opposed to those that receive endocrine therapy alone, if they have a lower or more moderate risk. And so just trying to tease out which patients do we think are going to benefit from chemo and which patients would benefit from, additional adjuvant therapy. And again, this is an individualized decision that we make with the patients and with the whole oncology team, whether that's just our medical oncology team and our surgeons and radiation, all those specialties really factor into these decisions. The RX-Sponder case really kind of helped us tease out, postmenopausal versus some premenopausal patients and who really benefited from endocrine therapy versus chemoendocrine therapy. Really our postmenopausal patients, there was not a big statistically significant difference in patients based on their recurrence risk and their therapy that we gave, including that endocrine therapy. But for premenopausal patients, we did see a bit of a difference and a reduced risk of recurrence for those, that did receive some chemotherapy. And so, just keeping that in mind based on their risk assessment for those patients. This graphic kind of talks a little bit, encompasses our oncotype and our assays that help us determine which patients might benefit from chemotherapy. We know depending on node status and of course menopausal status, some patients we feel would really warrant that chemotherapy. There's certainly a little bit of kind of a gray area for certain patients that are more moderate risk, and so those with a more moderate score, 11 to 25, those that are premenopausal, we may favor giving them chemotherapy as opposed to not for postmenopausal patients. So really, of course, the things that we're looking at, the tumor size itself, their nodal status, number of nodes, and of course their tumor grade, their Ki-67, those sorts of things that we look at. And then again, other things that we might consider as those genomic assays, things like oncotype, and then again, their age and menopausal status for those patients.
Thanks, Kelsey. I think that's super helpful. It's certainly gotten a lot more complicated over the past few years, but I think pretty exciting because ultimately more women are not needing to do chemotherapy and have a good outcome without chemotherapy. I guess a question back to you, Kelsey. How do you think is best when we're really talking to patients in clinic that we balance giving the information about risk and what we can do to decrease risk without really scaring people, right? You can't expect them to make a good decision for themselves without understanding risk, but how does that balance go?
Yeah, I think it certainly can be difficult because, patients go through quite a lot with a breast cancer diagnosis and treatment. And of course, including, surgery and radiation for many, and then, of course, some chemo, and then this adjuvant therapy. And so it can be overwhelming. And I find that, many patients, I I let them know, hey, this is maybe the long-term plan, but let's just take it, one section at a time to be able to kind of let them kind of grasp that and think about that. So, we may tell them, we're going to talk about endocrine therapy, for 5 years, and we may talk about additional, CDK4/6 or something, but that's going to be down the line. Let's do, this XYZ, first. And so just trying to kind of keep them aware, but not trying to get into all the nitty gritty details of each thing along the way. I don't know. I think that's somewhat helpful to some people, but again, there's other patients that love all the details at once, and so we just have to kind of tailor it to what our patient needs at that time.
I think that's a fantastic summary. Heather, I really think that oncology care is one of the specialties where, truly having the multidisciplinary team is really important. What kind of things are you thinking of from a pharmacy perspective when somebody's maybe starting new medicines because of a cancer diagnosis? What kind of questions do they have and how you may counsel them?
Yeah, that's a great question. So I think in kind of multifactorial, I think to some of the discussion that was had previously, there's certainly that education component under patients understanding why they're on this particular agent, the indication, side effects that may be associated. Like you mentioned, Kelsey, sometimes it's patients that want to discuss Kaplan-Meier curves and really want every aspect of that. And then there are some patients that it's really just kind of meeting them where they are in terms of what they understand about their diagnosis and therapy. And so I think a lot of that from my end is reinforcing some of that when I'm seeing a patient initially in terms of education, but also thinking about drug interactions, comorbidities, dose modifications. Are there comorbidities that otherwise may exclude someone from a particular therapy or modifications that we need to do on our end? I think, as you mentioned, it's taking one slice of it at a time. So, what that may look like from a chemotherapy perspective versus adjuvant endocrine therapy with CDK4/6 inhibitors. So, I think just very multifactorial and again, meeting the patient where they are in that process.
Yeah, absolutely. Kelsey, maybe one additional question for you. When we have so many cooks in the kitchen, but everyone kind of, has a different tool and skill set that they really bring to the table, how do you think communication works around a patient? What are some tricks that have kind of worked for you in clinic?
Yeah, I think especially in the adjuvant setting, maybe patients have done surgery and radiation or coming back to medical oncology for the adjuvant setting. Uh, One thing that I think we try to do with our patients is let them know that these adjuvant drugs are things that we're going to manage as the medical oncologist, and so things that may come up surgery related or radiation related, certainly we care about, and we will help differentiate and help those other teams weigh in as well. But kind of if we when we get to that point of adjuvant therapy, kind of let patients know that we're going to kind of be the driver in their management as far as those medications go, and to try and too many cooks in the kitchen can be confusing for patients, so they kind of know who's kind of steering the ship at that time.
I think the other thing that's really helpful that we have at our center is a multidisciplinary tumor board. So this really brings, medical oncology, radiology, pathology, surgical oncology, even plastics together to talk about the patient's case. Often when we really are talking about somebody prospectively instead of after the fact, we can kind of guide each other on what may matter for another specialty. A lot of conversations around lymph nodes recently, and, do we need to know somebody's lymph node status up front? Might it matter for radiation down the road, whether they're thinking about offering radiation or not? And so having, our conversation with the surgeons about that can be really helpful up front, I think. So let's come back to our case. Nothing has really changed on the left side. This is what we've already presented. But really kind of, maybe Kelsey, to tease out what factors here do you think about when you're determining risk? Like, of this paragraph, what are you looking at to kind of think about how likely this patient may be to have her cancer back, and what information do you need?
I mean, I think certainly the high grade and the positive lymph nodes. It would be interesting to see your Q67. And does she have any PR loss? Is she highly estrogen and progesterone positive? What is her percentage of positivity there? But I think her being high grade with those positive nodes definitely, piques the interest that maybe she needs a little something extra.
Yeah, absolutely. And Heather, maybe if you want to pipe in, how do you think things have changed or patients' experience around recurrent scores? Do you think that that's helpful for patients to quantify, and do they kind of understand the question that we're asking with those?
Yeah, I think there's certainly been a lot of evolution around risk recurrence score and how does that impact the ability of whether we're giving chemotherapy or not. I think patients also often see it now as, am I getting chemotherapy or am I not? But I think we also use it now for the decision around adjuvant therapy now as we'll move into CDK4/6 inhibitors. So I think patients really understand it more so as treatment decision making, but I do think also can provide additional information in terms of their overall risk.
Yeah, I absolutely agree, Heather. I mean, I think ultimately just explaining to the patient that we're trying to figure out, what is the risk? If the risk is high, then doing something additional, the magnitude of benefit they're going to get from that is going to be greater, worth it, right? And if the risk is low, then doing something else, although it may help, is small enough that it may not be meaningful for that patient. So I think that that is really helpful. I also just want to highlight that there's some additional resources here. This is a role play tutorial available as part of this program. I'm really kind of discussing risk of recurrence and how to talk to patients about that as well. So let's come back to our case. We have a little bit more information about our 69-year-old woman now. She does have an oncotype recurrence score sent, again, valid for up to three positive lymph nodes and ER positive HER2 negative disease. And this returns intermediate with a score of 22. In terms of past medical history for her, she does have hypertension that's really not optimally controlled, but she's on amlodipine, high cholesterol, and she's on a statin for that as well. She had recent pneumonia that she needed an antibiotic for, but is now recovered. And she also reports past episodes of seizure. We're not going to talk about the case right now, but we're going to continue to build on this and we're going to get back to the case a little bit later. So let's talk a little bit about the data about CDK4/6 inhibitors and really what we know about the benefit our patients may receive from taking these at this point. So, this was the Monarch E study. It was frankly a bit of a complicated study. Essentially, took patients that had hormone receptor positive, HER2 negative breast cancer, and everyone had positive lymph nodes. You could automatically qualify for this trial if you had four or more positive nodes. And if you had 1 to 3 positive nodes, you had to have an additional high risk characteristic. That could be a tumor size of at least 5 centimeters. It could be grade 3, high grade, or a Key 67 of at least 20%. Patients all went on to get their endocrine therapy, either endocrine therapy alone or endocrine therapy, where the first 2 years of that, they would also receive abemaciclib, which is given twice daily. This really was agnostic to the duration of endocrine therapy. Duration could be 5 years or it could be all the way up to 10 years, but really just had that additional 2 years of abemaciclib is what we were testing. So when we first saw this as a steering committee at the 24-month time period, I think we were pretty excited, but maybe a little nervous. There was a 2.8% benefit, and it was very exciting to see that the first time we looked. But then we had to kind of asked ourselves, were these patients maybe patients that had subclinical metastatic disease? Are these curves going to ultimately come back and close? And now that we followed this over time, at 36 months, it grew to 4.8% benefit. At 48 months or 4 years, it was up to 6% benefit. And now at 5 years or 60 months, we're seeing almost 8% benefit for those patients that received abemaciclib in combination with their endocrine therapy. So this really represents a 32% reduction in the risk of invasive disease-free survival event. I think the big question is are we actually translating patients to cure? So is this an in breast recurrence where we can just do surgery and somebody may be cured, or is this distant? And what we saw is almost overwhelmingly, these are distant events. We truly are translating more people to cure. So you can see of that 7.6% at 5 years, 6.7 was a distant recurrence event. So again, I think this is also helpful just to educate our patients about the benefit that we're really seeing here. In terms of overall survival, we do not see a difference in overall survival. I would argue that we shouldn't expect to see a difference in overall survival at only 5 years follow up. Even for somebody that has metastatic disease, we know our average survival is exceeding 5 years now. So, really, we wouldn't anticipate to see this quite yet in this trial, not to mention crossover in the metastatic setting. So, how can we also look at this? I think this is pretty interesting. If you look all the way over on the right at this overall survival interim analysis three, you can see the very darkest blue bars at the top that there's more than double the amount of patients that are living with metastatic disease now on these clinical trials and follow up that received endocrine therapy only compared to endocrine therapy and abemaciclib. So this really goes to explain, yes, we see this benefit in distant recurrence-free survival, but this is why we don't see the benefit in overall survival. They're still alive, but they're living with metastatic disease and are undergoing treatment. So, this is the FDA and the EMA regulatory approval, as well as the ASCO guidelines on the bottom. So, this was approved for FDA initially with this caveat of Key 67, which has now gone away. So, again, it's for everyone that had four or more positive nodes and or 1 to 3 positive nodes with one of those additional high risk characteristics that we talked about earlier. EMA looks very similar. They do give the additional caveat, which is important to remember. If somebody's pre or perimenopausal, it should be AI combined with an LHRH agonist, of which there are several different varieties. And so ASCO guidelines very much in line, abemaciclib for 2 years with for these patients that have high risk characteristics. And the ASCO guidelines do still include that Key 67 as one of the additional high risk characteristics that could make us think about abemaciclib. So, relatively new data. We don't just have abemaciclib in the adjuvant setting. We now have a second drug in the adjuvant setting, and this was ribociclib based on the Natalie trial. There were some differences in the Natalie design. I think the biggest one that people immediately noticed is that some patients that had no negative disease were included. So you can see for patients that had anatomic stage 2A, if they had no negative disease, with grade 2, they had to have high risk, either a high Key 67, a high oncotype, or some other genomic risk profiling, or be grade 3. And then it gets a little bit simpler when we're talking about stage 2B or 3. Those are kind of qualifying without so many different characteristics. So, first big difference is we're talking about including kind of not an ultra high population, but maybe an intermediate and high population. So more inclusive of more patients than the Monarchy study was. The other differences are over on the right side of the slide. You'll notice that ribociclib here is at 400 milligrams once daily. That's not the metastatic dose. 600 milligrams is the metastatic dose. So this is a lower dose in the adjuvant setting than we see for metastatic, and that's different than abemaciclib. The other thing I think we're all familiar with ribociclib is that it's an intermittent drug, 3 weeks on, 1 week off, where abemaciclib is continuous. And then the other thing that you'll notice here is it was 3 years of duration, not 2 years like abemaciclib. So very similar in terms of idea, but some important differences in the trial. So this is what we see so far. Natalie, we have not been following this trial. It came out more recently than Monarchy. So you'll note we only have 2 time points to look at, the 3 year and the 4 year. But we see a very similar pattern that it is increasing each time we're able to look at this data. So we initially saw a 2.7% improvement in invasive disease-free survival at the 3 year time point. This is now really almost doubled up to 5% at the 4 year time point. So I feel pretty comfortable as we continue to look at this. This is going to, the curves are going to continue to separate in a very similar fashion to the Monarchy curves. So one of the big questions I hear a lot is, well, how much was it that it's just the high risk patients really drove this benefit? Do you think our lower risk patients are really getting that much benefit? Do we really need to think about this maybe for our no negatives? And so I think the next two slides are helpful in answering this question. So over on the left, we have stage 2 versus over on the right, stage 3. And although you can see that the recurrence rates are a little bit behind in stage 2, they're increasing in a very similar fashion, 4.3% benefit here at 4 years. In stage 3, the benefit is 5.9%. This slide is maybe my favorite one because it specifically answers the question of node negative versus node positive. And what I love about this is that the node negatives had just as much benefit as the node positives, maybe 0.1% more if you're going to be really picky. But what that tells me that is when we take those node negative patients and we're allowing them to kind of qualify for the Natalie study based on those other high risk characteristics, grade, Key 67, the oncotype assays, et cetera, we're sufficiently picking a high enough risk that even the node negatives are really benefiting from a CDK4/6 inhibitor. What about secondary endpoints? Over on the left, distant free survival. So again, the majority of these really are distant events. We are translating patients to cure, and a very similar scenario on overall survival. We do not see a difference, and I don't think we would anticipate to. So, adjuvant ribociclib, it was a little bit later to the party, but it is now FDA approved. It has a little bit of a simpler label, essentially stage 2 and stage 3 early breast cancer with, quote, high risk of recurrence. EMA, very similar here. Again, they give us the caveat of remembering our premenopausal patients that really need to be on an AI with LHRH. And then ASCO guidelines essentially say we would recommend this potentially for anyone that met the Natalie clinical trial entry criteria. So this is a schematic really just helping us look for some of these differences. I can't imagine how general oncologists are really doing this across all disease type and remembering these tiny details because it really does get pretty specific. But again, remember on Natalie that we had node negative patients that were included. If they had lower grade, that intermediate grade 2, they had to have one of those additional risk characteristics, but node negative grade 3 and all node positive patients qualified. Over on the right for abemaciclib with Monarch E, uh, everyone was node positive, 1 to 3 positive nodes with additional high risk characteristics, or 4 or more nodes automatically qualifying. And so what we do know is that more patients are going to qualify for ribociclib, but certainly our higher risk patients will qualify for both. So, Kelsey, I may turn over the first question to you. I think that, when we go through this data, it really is pretty specific and pretty granular. How do you really talk to patients and how do you see them struggling with, the benefit when we talk about maybe, an 8% benefit in terms of recurrence and whether that's something that they want to sign up for to take an oral drug for 2 to 3 years? What are some of the things you think about?
I mean, I think that the patient's responses and kind of acceptance of doing this extra adjuvant therapy can definitely vary. We have some patients that want to leave no stone unturned and want to do everything we ask them to do, and certainly would sign up for abema or ribo, however long we asked them to. And, they'll take on the side effects and do just fine. And then we have other patients who would really rather just be done when they're done with surgery and radiation and chemo if they were to get it. And so kind of talking through what we feel as their recurrence risk, again, the 5, 10, 15 year down the road, and letting them know that, we think this would continue to keep that risk of recurrence low. We may have to spend more time on that for certain patients. So I think kind of understanding what the patient's needs are and what their goals are is certainly important. And then just knowing that depending on where they are, they just may need more information, less information, to make that decision.
Yeah, I think that's fantastic. Heather, what really stands out to me in the adjuvant setting here is, this isn't is as simple in a lot of ways as giving six cycles of chemotherapy. They come in, they're sitting in the chair. I know they got it. How do you really help counsel somebody on adherence about filling their prescription, about kind of the really long duration that we're asking for somebody to stay on these meds, and the fact that they have to remember them at home?
Yeah, that's a great question. And I think sometimes, especially at the beginning, because when we think about discontinuation, it really is usually happening in that first quarter. And I think it can be helpful to align adherence with monitoring. And so we'll go through some of the monitoring parameters with these agents as we continue through the program. But what can be really helpful is just ensuring that these patients have touch points. When we're thinking about this particular patient population versus our metastatic patient population, it's very different in that these patients are trying to resume some form of normalcy in their life. So I think it's helpful to provide that support, have touch points for them, and make sure that you're touching in when we're doing maybe their mid-cycle labs or having that follow-up appointment at end-of-cycle labs, but also not so much so that it's consuming their everyday life and then being able to get back to work. So I think it can be helpful just to ensure how are we following up with them, touching base on how are they taking their medications, following up with them in terms of toxicity management, what otherwise may be limiting factors to adherence, but also thinking about supportive care measures and how can we best support them so they're not discontinuing early on in treatment.
Yeah, I think you brought up a really important point about, how are we kind of supporting them to make sure that they're staying on. I think one of the really big kickers is side effects, and a lot of people don't adequately report their side effects. They don't want to complain. They for a variety of reasons may not want to talk about them. Maybe some of them are embarrassing, etc. Kelsey, how do you talk about patients kind of making sure that they recognize that we're all on a team and that, we want to help with the symptoms they may be having as well?
Yeah, I think encouraging them just to keep us updated on things that come up. We never want people to be suffering at home, and so asking them to let us know if any of the symptoms arise. Whether we may only see them once a month or even longer if they're not on a CDK4/6, and so we don't want them to suffer at home. So calling in and letting us talk through those side effects with them at different intervals so that they're not at home thinking that they need to just grin and bear it.
Yeah, absolutely. And maybe one last point, Heather. I think oftentimes we kind of overlook the financial toxicity of a lot of our cancer therapies. And I think pharmacy is often, the ones that kind of deal with that when somebody gets the sticker shock of going to get their medicine and maybe it was a little bit more than they anticipated. Can you briefly just talk about, how we may help patients through that and some of the resources we have?
Yeah, I think a lot of that can be aided by just full transparency when patients are initiating drugs. I always will say, this is the general cost, but these are the programs that are in place to support you. A lot of institutions, at our institution, we do have patient assistance technicians that will complete authorizations, follow up on patient assistance, help for patients that need copay cards if they have a high copay, or acknowledging that are some patients, especially our Medicare patients, that even in the setting of having active insurance can still have copays that are several $1,000s a month. And that can be fairly daunting for a patient when they're making that decision of, I want to be on this therapy, but that's really expensive and can be challenging for patients. So providing those pathways earlier on and say, this is what we're going to do. This is our process. This is too high. Then we go to patient assistance. We provide copay assistance cards going through the patient assistance process to obtain free drugs. So I think it's helpful to acknowledge upfront, yes, this can sometimes be a barrier, but then providing those pathways that can help in terms of solutions.
Thanks. I think that is so helpful. So we're going back to our case here. We had already talked about her oncotype score and some of her medical history. Kelsey, I guess the first gestalt is: do you think that this is a patient that we would be talking to about CDK4/6? And how does the conversation look when we may have two options on the table?
Yeah, I mean, I think certainly we would talk to them about a CDK4/6 inhibitor. You know, I think part of the conversation is duration, part of the conversation is side effects. Sounds like, the blood pressure is her main issue right now, doesn't have a history of colitis that would kind of cause us to, not look at ABIMA in and of itself. But I mean, I think, either option could be a good option for her. And so just kind of teasing out what her goals are and what might be important to her.
Yeah, absolutely. Heather, how does pharmacy, we rely on them heavily, but really, help patients in terms of what to expect based on the drug that they're on. Kind of this, I mean, people read the handout or the back of a Benadryl bottle, and it can be completely overwhelming. So in terms of really narrowing it down to this is what you're likely to expect, and this is what we can do about it.
Yeah, that's a great point. I think very often you may find a patient that's read the package insert and they've gotten into all of those less than 1% likelihoods and are absolutely terrified. And sometimes that can impact their decision to move forward with an adjuvant therapy. So I think what can be really helpful is emphasizing those are going to be, over your 20% in terms of what you're likely to anticipate. So you will kind of go into what those are, how I would manage and mitigate those. But again, being transparent in terms of these are the most common side effects, but these are the tools that we implement in terms of helping one to prevent them, but two also manage them. So I think that that can be really helpful. And then, including some of the really relevant, less than 10% that are important to know, but aren't necessarily going to be something that they can really anticipate. So I think it's, again, being transparent, providing tools in terms of how we can mitigate and manage, and letting them know that we have touch points, we're following you along the way, and our goals are the same as yours to get you through this therapy.
Great. Kelsey, sometimes I feel like patients, especially these high risk patients, may have already been through chemo. They went through surgery, maybe they've gone through radiation and now you're asking them to do something else. What about patients that just don't want to do anything else? How do you have that conversation around risk and why this may be a good idea for them?
Yeah, I mean, I think we certainly have those patients, and so again, I mean, it goes back to what their goals are, and so if they're let's say they have young children or they have school age children still, and just kind of reinforcing and maybe touching that driver in their own personal life to this would help prevent this from becoming back and being a metastatic disease. This extra therapy, we understand that it's a lot to ask and that it's not nothing by any means, but just kind of going back to what might be their driver for keeping this cancer uh, gone and cured for them. And so I think that can sometimes be helpful for certain people.
Heather, she's on amlodipine, which, we don't typically think of really affecting QTC. But looking at this history and the medicines she's on, are there any other questions that you would really be thinking about when you're kind of thinking about whether maybe abemaciclib or ribociclib would be most appropriate for her?
Yeah, that's a great question. So I think with ribociclib, we do have to be mindful that not only is it a CYP3A4 substrate, but it's also a CYP3A4 inhibitor. And so it can impact other agents that can be CYP3A4 substrates and alter drug concentrations. So I would want to be mindful in terms of, what is this patient taking for her epilepsy, if anything. Also being mindful specifically of the agents that she's on to see if there may be any additional drug interactions. So especially for patients that may have multiple comorbidities and may have a lot of other medications that they're taking, being mindful of polypharmacy and really assessing that drug interaction component there. And then aside from pharmacokinetic drug interactions, being mindful of pharmacodynamic interactions. And that's where we're thinking about QT prolongation and agents that could cause additional QT prolongation and exacerbate that side effect. So always important to check the med list.
I'm going to highlight this again, the role play tutorial. This really highlights the conversation around different treatment options and planning. And for our case, I think we talked about, that this patient really could be a candidate for either. Our patient here does start abemaciclib. She was sufficiently high risk because of the nodes in combination with the high grade. She has some mild arthralgias related to her endocrine therapy. She unfortunately has persistent and recurrent diarrhea in the first 2 cycles. She took a break, but then she got worried about taking the break. And so she went back on it and she had grade 2 diarrhea again. Her current dose is still 150 milligrams twice a day. But we're going to come back to this and some of the things we may be able to do to help her. So I'm going to hand over to Heather now to really talk about some of the adverse events and how we might be able to improve adherence, persistence, and probably most importantly, quality of life.
Perfect. Thank you. All right, so we're going to focus on some of the mechanistic differences and side effect profiles between these agents. So, we've been using CDK4/6 inhibitors for nearly a decade now in the metastatic space, but I do think it's important to understand the differences here. Not all CDK4/6 inhibitors are the same. So, we're not using palbociclib in the adjuvant space, but in terms of how ribociclib may differ, it does have a different selectivity for CDK4 and CDK6, but it does have a higher CDK4 CDK4 CDK6 inhibition ratio. So that's why you might see slightly lower potency specifically for CDK6 inhibition. Abemaciclib is a bit different in terms of its chemical structure. It has highest inhibitory effect on CDK4/6 with an inhibition ratio of 5 and thus additional activity on other kinases. And so that's what can also impact its potency and also induce a strong and sustained apoptotic effect. So understanding mechanistically that these agents are a little bit different. Now, specifically focusing on the two adjuvant CDK4/6 inhibitors that we have in this space and that we've touched on today, so abemaciclib and ribociclib. So first, I'm going to focus to the left here on abemaciclib, and again, going back to the mechanistic structure here and the CDK4 versus CDK6 selectivity. While we do see neutropenia, it is significantly less than what we see with ribociclib and does tend to be lower grade. But to some of the other things that we've mentioned so far, we do tend to see more diarrhea here, and it can be higher grade for these patients versus what's compared with ribociclib. Both of these agents can cause elevations in ALT, AST, and cause these transaminitis. That being said, the mechanism around ribociclib is more so thought to be autoimmune mediated and something to be mindful of if you're seeing that elevation in a clinic space in terms of how you're managing this. With abemaciclib, we do tend to see more thromboembolic events, which we'll touch base on a little bit later than what we see with other agents in this class. And then comparatively with ribociclib, we do have this caveat of QTC prolongation. And we'll go through how do we monitor and manage that, but being mindful that this is something that we see with ribociclib that we don't see with the other agents in this class. With abemaciclib from a dosing perspective, so it is twice daily dosing. So there are three different dose levels: 50 milligrams, 100 milligrams, and 150 milligrams, both taken twice daily. That can be with or without food. And then ribociclib, as we mentioned again, because of its selectivity, we do see more impacts on hematopoiesis, more neutropenia. So it does have that 3-week on, 1 week off of a 28-day cycle. A caveat with ribociclib is that it is preferable that it's taken in the morning because that does tend to have an impact on QT prolongation. I'm also mentioning dosing. So, as mentioned before, in the adjuvant space, ribociclib is dosed at 400 milligrams per day. You're not starting at 600 milligrams per day like you're seeing in the metastatic space. And so, there's really only one dose level reduction that's an option here in terms of going to that lower dose at 200 milligrams. One other difference between the two with abemaciclib, tablet strengths are 50 milligrams, 100 milligrams, 150 milligrams, whereas ribociclib only comes in 200 milligram doses. So you're making that dose with a 200 milligram tablet. Sometimes that can be helpful in terms of dose modifications, but just being mindful of that. Again, thinking about the main toxicities that we see with CDK4/6 inhibitors, specifically thinking about our special patient populations. I think we know, there was a Monarch subgroup analysis looking at older patients, and we know that older patients do tend to experience more toxicity with these agents than what we may see with our younger patients. Also, thinking about patients with cardiovascular disease having a higher risk of thromboembolic events or QT prolongations. And then again, patients with hepatic impairment are more likely to have a transaminitis that's irreversible. And then patients with multiple comorbidities are more likely to have some of the side effects that we're going to talk about today. Specifically focusing on the toxicity that was seen within Monarch E, you can see endocrine therapy here on the right, and then combination of abemaciclib here on the left. You can see a lot of the side effects that we've mentioned thus far, but they, of course, have higher percentages within our CDK4/6 inhibitor group. Most of these being grade 2, or grade 1 rather, but you can see some grade 2 and some grade 3 events. Specifically focusing on VTE, roughly 2.5% of patients did experience VTE, with 1% of those being PE, and then 3% of those patients roughly experiencing ILD. So side effects that aren't very common, but being mindful of with this patient population. And then I think we've talked about some of the side effects and how do we manage these, how do we mitigate some of these. But I think also being mindful in terms of dose reductions can be helpful. Thinking about Monarch E, it was seen that these dose reductions were seen earlier on. Over 40% of patients did require a dose reduction. And like I mentioned, usually earlier on in this first few months when patients were initiating therapy. 30% of patients discontinued early, and roughly 19% of those were due to adverse events secondary secondary to therapy within that first 6 months of treatment. So I do think it can be important in terms of how do we mitigate and manage that for this patient population. And I think it's really important and using this as a tool in our toolbox in terms of thinking about dose modifications. But often that is met with this concern from patients that are we compromising efficacy and what is the impact that that may have on efficacy? So there was a subgroup analysis looking at this specifically focused on relative dose intensity and how did that impact efficacy. And they broke that down into three different groups based off of relative dose intensity. So patients that fell in that 0 to 66%, 66% to 93%, or patients that were 93% or greater. And as you can see from the curves here, there was no difference between them. So, in terms of invasive disease free survival, it's very similar between groups. And I think that can be helpful for patients when having that discussion and reinforce that it's really important that we're maintaining in that 2 year duration for abemaciclib, regardless of what that dose may be, versus early discontinuation. Another concept here that is ongoing and is being investigated is the concept of dose escalation. We have some retrospective data here, but there's a prospective study with TRADE. This is a phase 2 dose escalation trial that's specifically looking at escalating abemaciclib with the thought that, the biggest side effect that we see with abema does tend to be diarrhea. The concept that this may be tachyphylactic in nature and that patients may improve a lot of their side effects over time. So the TRADE study works at doing abemaciclib starting at 50 milligrams twice daily for those first 2 weeks, then increasing to a 100 milligram dose for those last 2 weeks of that first cycle, and then increasing ultimately to the highest dose at 150 milligrams. Primary endpoint is a composite of adverse event rates, and then focusing on discontinuation of adjuvant abemaciclib for any reason or a need to dose reduce by the first 12 weeks of therapy. And then multiple secondary endpoints, including discontinuation and hold rates, incidence of grade 2 through 4 events, as well as adherence and dose intensity and quality of life. And then finally, thinking about our endocrine backbone. So I think this is really important. We all have a lot of experience with our aromatase inhibitors or in combination with tamoxifen, but it is something to note with abemaciclib because it does have a VTE risk that in combination with different endocrine therapy backbones, you may see an increased risk. So specifically drawing your eye to the middle here with looking at tamoxifen. So you can see tamoxifen in combination with abemaciclib did increase VTE risk to 4.1% versus 1.7% with what we see with our aromatase inhibitors. So when abemaciclib is used in combination with tamoxifen, you do have to be mindful of risk factor with VTE. Probably the biggest side effect that we're almost familiar with abemaciclib is going to be diarrhea. So I think it's really important when educating patients on this side effect. I always make sure, do you have antidiarrheal at home? Do you have a loperamide or Imodium at home? Sometimes it can be helpful to write a prescription, even though it may not be covered by insurance. Sometimes it can be cheaper for patients, and then just actually having it on hand and having it there when they need it. I think it's important to emphasize maximum dose of loperamide, 16 milligrams in a 24-hour period for these patients versus what we would otherwise see on the packaging. So ensuring that they have that information. And then sometimes just emphasizing dietary changes. So foods that, drinks that are caffeinated, high sugary, high fiber, those are all foods that can increase diarrhea. So sometimes, especially initially at the beginning of treatment, it can be helpful to have some of those conversations in terms of dose modifications. I always instruct with patients in terms of how we manage diarrhea that it can be helpful initially to be more responsive and waiting for diarrhea to take place, having a diary or a notebook at home and monitoring and writing those things down. But over time, if we find in that first week or so that someone is consistently using 4 tablets of Imodium every day, that then we're going to switch over to a proactive front, and then trying to schedule Imodium, and then we can taper that down as needed. So I think it can be helpful to just really emphasize management for diarrhea here, and then understanding the different grades of diarrhea and how that may impact dose, and really trying to get control of diarrhea earlier on, so patients aren't discontinuing without maximizing some of the supportive care strategies. Specifically for diarrhea, if patients have maximized loperamide or Imodium and they're still having uncontrolled loose stools, thinking about prescription antidiarrheals like Lomotil. Sometimes, in some ways, we can extrapolate some data that we've seen from the control study with neratinib, thinking about budesonide or cholesterol. Sometimes those are other agents that can also be helpful if someone is consistently having refractory diarrhea with abemaciclib. Something that is a caveat that I think is really important because we do not see this with the other two CDK4/6 inhibitors is that abemaciclib can impact MATE transporters, which can cause this false elevation in serum creatinine. And this is something that's usually realized by the end of that first cycle in terms of when you're seeing this change in serum creatinine. If you're looking at the literature, usually it can report anywhere from a 40 to 60% increase. I'll say anecdotally in the real world space, I've seen people double their serum creatinine. So I think it's being mindful that this is a side effect that we see with serum creatinine, but also noting that when we think about diarrhea and dehydration, this can also lead to elevations in serum creatinine that would otherwise be managed differently. So I think it's important that if you're having consistently high serum creatinine that's elevating over time, despite patients getting to a steady state, that it can be helpful to get a cystatin C to give you a better idea of really what is their renal function. All right, so transitioning over to our other CDK4/6 inhibitor. So this is ribociclib. Again, we mentioned that it's at a 400 milligram dose. Thinking about the side effect profile that we see with ribociclib, we still have to be mindful of neutropenia. We actually tend to see a little bit more of that. So when we look at the NATALEE data, you can see that roughly 60% of patients experienced neutropenia, with over almost half of those being grade 3 or grade 4 events. But specifically focusing on febrile neutropenia, that risk is very low, less than 1%, as you can see here. The other thing that I want to mention that I alluded to a little bit earlier was this concept of QT prolongation. And we'll delve into that a little bit more in terms of how do we monitor, but it is something that is important when we're using this drug. As you can see, roughly 5% of patients any grade within the NATALEE study, and then 1% of those being grade 3, grade 4 events. But we do see lower rates of neutropenia and QT prolongation at the 400 milligram dose, which is why it's utilized in the adjuvant space versus that 600 milligram dose. In terms of the LFT abnormalities, and as I mentioned earlier, the transaminitis that we can see, that is not dose dependent. So that is something that we can see regardless of dose intensity. And then, as we discussed previously with dose reductions with abemaciclib per monarch E, this is very similar within NATALEE. So they also looked at dose intensity and looked at dose reduction. And I mean, here you're only having 2 points in terms of your 400 versus your 200 milligram dose. But again, regardless of relative dose intensity, patients maintained the same level of efficacy. This is also seen here between these curves when you're comparing these two groups. So again, invasive disease-free survival was similar in patients regardless of the 400 milligram versus the 200 milligram dose, and is consistent. As I mentioned, with ribociclib, we do tend to see more hematologic toxicity. So it is important with all of these agents, but especially with ribo, that you are getting baseline CBC with differentials at baseline, mid-cycle, and end of cycle for those first 2 cycles. And then also getting monthly labs thereafter. So that's something that's going to be important. And then being mindful of grade of neutropenia. So for patients that may have a grade 1, grade 2, does not require dose modification. But if you're seeing a grade 3 event, that is a hold, waiting for count recovery, and then considering a dose reduction in the future, but especially if you're having a grade 3 or grade 4 event. All right, now focusing in on the QT prolongation that I mentioned. So this is something that we do specifically see with ribociclib, and it's hypothesized that this is really a drug-induced downregulation of particular genes. So it's a KCNH2 expression, and it regulates SCN5A and SNTA1. And this impacts voltage gated sodium channels that are mainly expressed on cardiac myocytes. And that's why we specifically see this with ribociclib, and we do not see with abemaciclib because they do not alter the expression of these genes. In terms of QT prolongation, so it is important at baseline that you're getting ECGs with these patients and checking for specifically a QTCF, which we'll kind of go through here in a moment. You want to ensure that QTCF is less than 450 when patients are initiating. So you want to avoid in patients that otherwise may be over that threshold prior to starting, but also identifying any electrolyte abnormalities, checking magnesium, potassium at start. And then this is contraindicated in patients that may have arrhythmias or uncontrolled cardiac disease because of that increased risk of QT prolongation. Drug interactions is actually an issue for this entire class of drugs. I'd be remiss as a pharmacist if I didn't mention it. But I think it is especially important with ribociclib. So, one, ribociclib is a CYP3A4 substrate, as is every CDK4/6 inhibitor that we're using in this space. But it is also a CYP3A4 inhibitor, and it is a moderate inhibitor. So, that's really important in terms of the impact that it can have on other agents that patients may be on, especially if patients have multiple comorbidities. So being mindful of any potential drug interactions, but also thinking about other QT prolonging agents. So this can be, SSRIs, SNRIs, pain management, especially an issue in the metastatic space, but we also deal with a lot of these agents in the early stage space as well. So being mindful of agents that could prolong a QTC. And then ECG monitoring. So this is recommended at baseline and then mid cycle. This is actually a recent change in terms of the package insert. It is no longer required at an end of cycle prior to cycle 2-day 1 start. So the amendment is now that it's baseline and mid cycle, with the thought that patients are going to be at a steady state by mid cycle, and that change would be realized at that point. And then it's also really important, as I mentioned, in terms of being mindful of electrolytes, that we're maintaining and monitoring potassium, calcium, phosphorus, and magnesium prior to initiation, and being mindful of that at each cycle in case these electrolytes do need to be modified to help reduce the risk of QT prolongation. All right, so going back to QTCF and what is it and why does it matter? And so many of the ECGs that are used in academic institutions are set to the Bazet formula. Bazet formula is actually thought to overestimate during tachycardia and underestimate with bradycardia. So this can directly impact the QTC that's being reported. Fredericia formula is what is recommended and used, not really with just ribociclib, but a lot of our oncologic agents and targeted therapies at this point in time. And that's more so because it tends to be more accurate in terms of tachycardia. This is what was included within the Mona Lisa trials. So then there was this really good case report specifically for ribociclib that included 82 patients, and they looked at baseline ECG using the Bazet formula and found that 19 of those 82 patients were excluded because they had a QTC that was greater than 450. However, when they recalculated these patients, they found that really only included 17 of 19 patients. So one-way analysis found that statistical significance between a Bazet formula was 471 versus a QTCF, which was 439. So again, showing that you can have that overestimation depending on the formula that you're using. All of that to say the recommended formula is QTCF. MedCalc does have a really great calculator for this. There are a few different calculators, but ensuring that when you're getting an ECG, most are in the Bazet formula, but being mindful of which formula is being used and then correcting those. So when you're starting a patient on ribociclib, you want to ensure that you're utilizing the QTCF. All right, now in terms of how do we manage cardiac effects that we may see with ribociclib, so for ECGs that may show a QTCF greater than 480, you want to hold ribociclib, and then you want to wait for this to improve. If QTCF resolves to less than 481, then you can resume with one dose level reduction. However, if QTCF continues, you're going to wait till it resolves, and then again, wait until you're down to that less than 481 before you're restarting. I think the other big important thing here is being mindful of adherence and all of the factors that can influence adherence for patients. Some of those can be patient related, therapy related, disease related, but other factors that can be related directly to healthcare systems, and then social and economic impacts it can influence too. So I think it's important that we're mindful that this is multifactorial and really trying to meet patients where they are and trying to address some of these. So some of these are on the patient aspect in terms of understanding necessity, benefit, quality of life. We're thinking about therapy related factors, side effects, modifications, duration and variations of therapy, and also thinking about polypharmacy or pill burden, which can often be a challenge. For patients that have comorbidities or node positive disease, it can be disease related factors to be mindful of. And then healthcare system related factors. So, thinking about shorter duration of follow up visits, errors that can happen with prescribing, different physicians that can be responsible for follow up, relationship with providers, and then lack of patient involvement in decision making. There are so many things that we can do on a daily basis that can impact these factors as well. And then the social and economic related factors. And we've hit on some of these too in terms of age, out of pocket cost, lower income, and education level are all factors that can be directly related to adherence. So, what are we doing to help improve adherence? So, I think in terms of therapy related interventions, trying to simplify our regimens, the education surrounding the use of these drugs, having clear and direct instructions, patient tailored prescriptions, and then often being mindful of our monitoring and reassessment of treatment can all be helpful. And of course, management of side effects. And then in terms of patient related interventions, so interventions that can redress misconceptions around treatment, communication, I think, is one of the most important things in terms of addressing interventions with our patients, assessment of psychological needs, sometimes using conventional versus non conventional ways of education. So, whether that be brochures or digital education, that can be helpful. And then also thinking about remote monitoring tools that sometimes can be helpful for adverse events and adherence. So I think these are just a few that can be helpful that we can help intervene in terms of improving adherence. All right, now Dr. Becker Hamilton.
That was fantastic. I love that you brought up handouts. I think sometimes we're giving people so much information in clinic that really just having that written down that they can refer back to is incredibly helpful, particularly for families who now want to ask, what was said. um, so, Kelsey, I think that there are a lot of side effects of the drugs we prescribe. Maybe tell me a little bit about how you advise patients of how to communicate with us about them, and how we rely on the other colleagues in our clinic to help us take care of these.
Yeah, I think, kind of going over what we might expect before we prescribe anything. Of course, if they're going to take ribociclib, that we expect their counts might drop, their LFTs might rise, those sorts of things. Any symptoms that they may experience. Again, if they're going to take abemaciclib, that we might be watching out for diarrhea or whatever it may be, but letting them know what to expect and then letting them know this is what you can do at home when this starts, and then this is when to call us. So calling our triage nurses and making sure those teams are aware, when they need to be managing things on their own and then kind of talking through things with the patients, and then of course notifying the provider team as well. So kind of letting the patients have some tools to use at home to start out, but knowing to call us quickly if they're experiencing things that we need to intervene about.
Yes, absolutely. The ostrich head in the sand, pretending it's not there, does not improve the side effects. So we have to work on those. Heather, I've maybe changed the way I talk to patients a little bit about adjuvant CDK4/6s. We didn't get into a lot of this, but about the data really showing that patients that have dose reductions do equally as well as those who don't. And in fact, in the clinical trials, dose reduction was pretty common, about 40% of patients. I've started really telling my patients, if you're not tolerating this, there are things we can do like a dose reduction. So let me know, don't just stop it. But otherwise I find sometimes that people come in and they're just done. They're stopped it. They already decided they're done. And you say, well, we could dose reduce it. And that's not what they were prepared for. And it doesn't work out well. So is that your experience? I mean, do you kind of let people know that there are some tweaks if they don't tolerate it, so they don't kind of get frightened at home?
Yeah, you're exactly right. So when I sit down with patients and we go over these agents, we go through the side effects, but I specifically write out if this, then this. And so that there's a kind of a direct pathway. And I think sometimes also explaining to patients, we say you're going to have diarrhea, but how much diarrhea and how do we quantify that? And some patients take that to mean if I'm having more than one episode over my baseline, then we need to ring the alarm. And there are some patients that will have 20 episodes in a day and won't call you. So I think it is really helpful to provide, kind of a general understanding of how we grade diarrhea, for example, with the abemaciclib, and then providing those tools. And I'll say maximize the Imodium. If you've maximized the Imodium and you're still having diarrhea within a 24-hour period, then you need to call us. And then this is what we're going to prescribe likely. And this is what we're going to do. And this is what that pathway may look like. But I do think, to your point, it's really helpful for patients to hear at the very beginning that dose reduction and dose changes does not compromise the efficacy of therapy. And I think if that's something that they're hearing earlier on, then they feel more comfortable with that concept. I think providing them that with that information, I feel like when we go through education, it's, toxicity mitigation and management, but so important to include the caveat of yes, dose reductions happen. Most people require a dose reduction, and it doesn't compromise efficacy based off of the data that we have. And I think that is really helpful to reinforce those concepts. So, to your point, patients aren't just discontinuing and they're not willing to retrial when they're coming back in.
Yeah, I couldn't agree more on that. So, come back to our case here. If we remember, she had taken a break of abemaciclib because of the diarrhea. She really got worried about that. She went back on it. The diarrhea came back again. She's on 150 milligrams BID. She's really not taking other medicines. Kelsey, what would be your first recommendation for her if she's having diarrhea?
Yeah, I mean, I think asking is she using Imodium and is she using it appropriately? But I mean, I think it's definitely warranted to just go down on her dose and try at 100 milligrams and see how she does. Now, some patients, could do just fine if she's not doing very much Imodium or something like that. She may be able to manage just fine, but just trying to tease out. Are there other things we can do to treat the side effects, or do we just need to go down a bit and kind of see how she does with that?
And I'm going to just go quickly around the room for summary and maybe key takeaways from your perspective. Heather, maybe you first.
Yeah, I would say so. With this new age of adjuvant CDK4/6 inhibitors, I think that's being mindful in terms of indication and being able to identify which patients may be eligible for which agent. For patients that may be eligible for both, really being mindful of the associated toxicity profiles and trying to find the best agent for the particular patient. So I think that can be helpful. So and then aside from that, always mitigation and management of toxicity.
Fantastic. Kelsey, you?
Yeah, I think the main thing is just doing a really a personalized approach for each patient is going to be a little bit different, what every patient needs. And so just trying to talk with them about what their goals are and are they willing to do these additional adjuvant therapies to be able to have better survivability, and just let them know that we can help them get through that and we can help them manage any side effects that do come up.
Yeah, I completely agree. Honestly, it's a pretty exciting time. I feel like, we all talk about personalized medicine, and in 2025, we're really doing that. We have better ways of predicting who may not need chemo, and it's not a one size fits all. And then on the other hand, for people that are higher risk, we have additional agents like the CDK4/6 inhibitors to offer them. I really enjoyed this conversation. It was fantastic to have pharmacy, NP, and physician kind of all talking. I think all of us realize that this is how we manage patients in clinic. But, just like child rearing, it takes a village to take care of patients with cancer. And I've really enjoyed kind of bringing everybody's expertise to the table. Thank you so much for attending to those of you that listened. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/DEJ860.